Hello everyone. Thank you for joining today's APMs 101 for the 2019 performance year of the Quality Payment Program webinar. The purpose of this webinar is to provide an opportunity for current participants, new clinician types, support staff, and other stakeholders to learn the basics of alternative payment models, APMs. The presentation will be followed by a Q&A session where attendees will have the opportunity to ask questions. Now, I will turn it over to Adam Richards, Health Insurance Specialist in the Center for Clinical Standards and Quality at CMS. Please go ahead.
Okay, great. Thank you, and hello everyone. Thank you for joining us today. This webinar is a part of our 2019 Performance Year series. So today we are going to talk about alternative payment models, which we'll refer to as APMs for the remainder of our talk, but more specifically advanced APMs under the Quality Payment Program. So full disclosure, this is and it's meant to be a 101 level webinar. Our job today is to break down the APM track as best we can. So we anticipate that for many on the call, this may be your first foray into the alternative payment model landscape. So we want to start slow and build a strong foundation so that everyone can understand APMs and advanced APMs a little bit better. We're not going to get into the details of our models, and we're not going to talk too much about some of the recent rules, such as the new Pathways program under the Medicare Shared Savings Program. However, we will be offering additional webinars on many of the components in our talk today at a later time and date for those who are interested in diving a bit deeper. I always encourage you to visit our website, the Quality Payment Program website, qpp.cms.gov, and signing up for the listserv. It's the best way to stay in communication with us. We also push out all of our webinar dates through that listserv. So if you haven't done so, please do that. Okay, I'm going to charge forward to the next slide, please. And we'll be on the topic slide. Should be on the topic slide. There we go. Now we're moving forward. So again, today we'll do a quick overview of the Quality Payment Program. Also, just start to talk a little bit about APMs at a high level, really talking about some of the key terms we want you to know that will help you communicate about APMs, understand the structure, how we as in CMS and certainly the Innovation Center, the Center for Medicare and Medicaid Innovation, goes about creating APMs. And then we'll dive into the deeper components. So, talking about the advanced APM track, getting into a little bit more nuance around advanced APMs, but then also focusing on our new all-payer combination option, which begins this year, 2019 performance year. And also talking a little bit about what we call MIPS APMs. Some of you may be familiar with this concept, but this is an additional piece of the Quality Payment Program that we think is important to discuss for those who are participating in MIPS through an alternative payment model. Of course, as always, we will wrap up with some of our additional resources that are available and where to find help, some free technical assistance. So moving on to the next slide, just to talk a little bit about the Quality Payment Program at a high level. So again, as many of you may be aware, this was established under by the Medicare Access and CHIP Reauthorization Act of 2015. The Quality Payment Program consists of two avenues for participation, which you can see on screen. We have the merit-based incentive payment system and advanced alternative payment models. So we really look at both pathways as foundational elements to help drive value. However, the ultimate goal of the program, which really reinforces the intent of the MACRA law, is to encourage the movement of clinicians and practices into APMs and advanced APMs. Now, we do expect many clinicians may initially fall into the MIPS side of the program, which will ultimately help them build a strong infrastructure to meaningfully participate in value-based arrangements and in a value-based system. But again, our ultimate goal is to drive value through APMs and move clinicians over into the APM landscape. So we're not going to spend a lot of time discussing MIPS in any sort of depth today, but if you are interested in learning more about the topic and about the pathway, I highly encourage you to check out our MIPS 101 webinar recording from several weeks ago that is available in the webinar library on qpp.cms.gov. So at this point, I'm pleased to turn it over to Dr. Corey Henderson to kick off our discussion about APMs and advanced APMs. Corey?
Good afternoon, everyone. Thank you for dialing in again. We're really excited about this because we are moving now to a place where we'll be getting to take our time to educate, and that's very important to us because we want those that are participating in the program to do very well, not just do well, and also to understand the opportunities of joining alternative payment models. Next slide, please. So today, I'm going to present this information in a way that it is more of a story, and the reason why I want to do that is because we recognize the power of storytelling. So if I make a statement or reference you or the clinician or those that may be submitting data on their behalf, just note that I'm doing that to kind of tell a story so that you can picture how it may look in the practice setting. So your clinician comes in and the CEO comes in of the organization or those that are the executives, and they ask you, what is this alternative payment model stuff that you keep sending their way in their email box and CMS keeps telling them about? And you would say to them, well, an alternative payment model, sir or ma'am, is actually, it was a established policy under the CMS Innovation Center, and the authority came through the 1115A Social Security Act. And what does that mean? It actually comes out of the Affordable Care Act that allow for us to look at how we do demonstrations. And a demonstration is nothing more than how we present something. So how we demonstrate that there's either quality or cost savings. So some of the things that we may recognize as alternative payment models under the Medicare Access and Chip Reauthorization Act that Adam just spoke about was the CMS Innovation Center models. And those are not the Healthcare Innovation Awards that many people heard of. There's also the Medicare Shared Savings Program. We also recognize that demonstrations under the Healthcare Quality Demonstration Program, and those will be identified specifically if you see something like that. And then also demonstrations required by federal law. One example of that would be the what we recognize now as the Medicare Part D. That was once a demonstration, what we call a model to test whether or not there was cost savings in how we pay for pharmacy and other forms of benefits related to medicine. Next slide, please. So now that we talked about an alternative payment model from the legislative perspective, let's talk about it more generally, how it applies to your practice. Well, as your practice is thinking about joining an APM, an advanced APM, or what we would call a MIPS APM, which we'll define later, you're thinking about, well, one, what are the incentives that I get, and why would I want to do this? Well, one of the incentives is that we're looking to see if there's opportunity for the model and its design using different modalities or different care models to look at high quality and cost-efficient care. So can we provide quality and save money? Can we provide savings and quality may be minimized? But overall, are we going to be able to provide both? And then also, what is the specific condition or the care episode or even the population being the population of patients that I'm going to see? Are these patients ESRD patients? Are these patients that are specifically patients that you focus specifically on because they have end-stage renal disease or other forms of care? In addition to that, we also want to think about, hey, before I make this decision, what are the significant opportunities that I have to participate? Are there open applications? Are there things that I need to consider when I decide to work with another organization that has billing rights? And we'll go further. Next slide, please. So here's the opportunity to think about the structure. So that clinician, that practicing physician that comes into your practice, that stands there talking to you, or you are the clinician, has an NPI number. That NPI number assigns its billing to what we call an APM entity or the TIN. That is nothing more than the tax identification number by which we recognize when those billings come through, that NPI or that clinician has assigned its rights over to that organization only for purposes of billing as they work with that organization. And many clinicians actually work with different organizations or different billing entities. So again, we don't want it to be scary. We want it to be something that's more realistic. So a clinician may work in a hospital setting. They may also work in a small practice, or they may participate in more than one practice. In that instance, that term is used loosely to represent the APM entity or how it's billed. Next slide, please. So now you've explained all of that, and people are saying, you know, we're sitting around this room at this conference table, and you're telling us all this good stuff, but we still don't really get it. So what you decide to do is take a different step and say, well, let me tell you a little bit about how, first of all, we design APMs. I'm going to put my CMS hat on here and tell you a little bit about some of the things that I learned through my call. One, that we want to first understand what is the type of APM or alternative payment model you want to design. Why do I even want to do this? Second of all, what is the clinical practice transformation that we're looking for? Are we currently noting that a lot of patients are coming in for a visual check? They're not being checked in a physical way. They don't have to go an x-ray. They don't have to have anything physically done. Or do we have systems that allow for that? So maybe we want to look at telemedicine. So that's one clinical practice transformation. Rationale and evidence. What is the evidence or the evidence-based practice that we want to build upon that's already been done? And in epidemiology, we recognize that more than one study of something being done, we can find value in it. So a lot of times we look at building APMs around things that have already been done. Scale and scalability. Who are the participants that we want to build this out to? Are we talking about including other types of clinicians, specialists, primary care physicians? And how is this alignment going to work as we align ourselves across nationally and look at other regions? How does it align to recognize that there may be other payers already in this space of care that we want to do work? Is there going to be quality improvement in the work that we do? And then also, how operationally feasible is this? As we look at the organizations, we want to think about, hey, if we decide to do this, what is it going to require for us from a systems perspective? Can we use our existing certified EHR technology? Do we have to report on quality measures that we currently do not report on? What is the work that's required as we begin to build and design this alternative payment model from a perspective of getting it approved? Next slide, please. So now you talked about that, and these are just some of the key factors that we consider when looking at the alternative payment model design toolkit. And you can find this right on the website under qpp.cms.gov. It's about a 46-page document that gives you some good information around how alternative payment models are designed and some of the key factors. Number one, what's the alignment with key CMS and HHS goals? If we jump forward to slide, not next slide, but number 7, what's the potential for quality improvement? Next column over, 13, how do we evaluate the feasibility of doing this? Number 14, is there even stakeholder interest and acceptance? Do people even care about what we're about to do, and is there any need for this? And then number 20, the scalability that we spoke about. How scalable is this? How expensive will this be? And how many clinicians are going to be excited about the opportunity to join once we develop this alternative payment model? So that helps you a little bit to understand that it's bigger than just us putting together an idea, but all of the things that require for this to actually stand up from the standpoint of its foundation. Next slide, please. So keep in mind that I'm moving at a pace that allows you to grasp the information, but I will leave enough time in there for question and answer at the end. I just want to make sure that we don't rush through this information and you guys leave with more questions than you have answers. So here we talk about different ideas that have already been developed, what we call concepts into actual alternative payment models. So when you go to the comprehensive list of APMs on qpp.cms.gov, if you go to the About tab and then you drop down to the Resources, you'll note there that there are other ways that you can look at what alternative payment models exist. When you go there, you can change any of the filters. You can do all for the year, so you can change what type of information you're looking for. A lot of times I leave the filters alone, or I may change my filters to alternative payment models if I'm looking for a specific document. But under the comprehensive list of APMs, you'll see there that we have different headings. What's the APM? So what's the name of the alternative payment model? Let's take a look at the second one, the Comprehensive Primary Care Plus model. Now, what is that model specifically? Well, it meets the MIPS APM under the APM scoring standard measure. So what do we mean by measure? Not in the form of quality measure, but the way that we measure the model itself to say that you get some additional points for participating, and we'll talk about that. Is it a medical home model? We'll talk a little bit about that. Does it use the certified EHR criterion or the certified EHR technology criterion? Yes. Are there quality measures that are going to be reported? Yes. Is there a financial risk criterion? Yes. And if all of those are true, then this is an advanced APM. So that's a great way to kind of look at, hey, why is this saying that this is an advanced APM, plus it has yes under all of these headings? Because we want to make sure that, one, it is using certified EHR technology, the quality measures criterion matter, and that financial risk criterion matter. And it does not have to be a medical home model. That is one option. And it does not always have to be a MIPS APM. Next slide, please. So these are key terms to know. You can go to the next slide, please. And I'm not going to read this to you, but you have some key things here, such as the NPI, the tax identification number, the APM name, as I just spoke to, the subdivision name. So we may say CPC plus, and if we start mentioning tracks or a specific type of model underneath that name. And also the APM entity name would be the entity or organization name that you have assigned your billing over to. So your name may be John Smith or Susan Bailey, and you decide to assign your billing over to, for instance, Maryland Healthcare System, and Maryland Healthcare System is just going to do primary care. When you see the APM entity, it is not saying that you are the entity. It just means that you are a participant in that entity. So there will be a list of NPIs that participate as part of that entity that you have assigned your billing over to. So that name is not always going to match your specific name, but you could be a participant in that group or that entity. Next slide, please. So here's some other key terms. Again, I'm not going to read this to you because you will be getting more information later on, but you'll get the APM entity. We talk about advanced APMs. Again, it applies to specific clinical conditions, care episodes, or populations, but we give you additional incentives and incentive payments to provide high quality and cost efficient care. Are you an affiliated practitioner? All that is a practitioner that works alongside or has a contractual relationship with the APM entity that is going to help the work get done. So that work that's getting done specifically is going to be caring for those patients. We also talk about the MIPS APM. And that MIPS APM, again, we're going to talk a little bit about what the APM scoring standard is, the participation list, and in addition to the participation list, we also describe the QP. And a lot of people on the call will be excited to hear about the QP, and that's the main reason why people are interested in advanced APMs, because that QP, the qualifying APM participant, is eligible for a 5% bonus based on the amount that has been paid out. And basically it allows for you to give an opportunity to get more money to the organization, that billing 10 or that entity. And when we say the amount that's paid out, you're going to bill a certain amount, and then the patient may have a certain portion that they pay or the amount that we actually pay. So it may not always match the total amount billed. So we're actually going to base the 5% off of that. Next slide, please. So here are some other key terms, and this is more related to specifics around advanced APM and specifics around definitions there. So full capitation, that has to do with all of the per capita, and the amount of money that we're talking about paying, and that has to do with no settlements on the back end if we do reconciliation in some models. And again, these terms are not all relevant to every model, but just some terms that you'll find helpful as you begin to read about or learn about alternative payment models and advanced APMs. We don't have right now a lot of emphasis on this, but we're trying to get to a place where organizations can actually bill for a population and or receive payments and prospectively or retrospectively for the work that they do for a group of patients that you would care for. The APM entity bears more than nominal risk or full risk. This would be downside and upside. So downside risk would mean that there's potential for you to have some loss, and upside risk means that there is a potential for you to either share in savings or make additional money beyond what you normally would bill for. And then the cash flow, total risk, marginal risk, minimum loss rate, financial risk standard, and nominal amount standard. These are all key terms that are defined there for your pleasure to read and have a good time. And if you have any questions, we'll be happy to help you answer them. But these are terms that are often used more relevant to an accountant or whoever does your financials in your organization. Next slide. So with that said, we're going to move a little faster now. I just want to give a little background. I'm going to take the next 15 minutes or so to give you a little more understanding around the specifics. So here's some basic structure. We have advanced APMs. Advanced APMs require three specific things, and these they must meet to be an advanced APM. One, the certified EHR technology. We also require that 75% of clinicians in an organization or 10 use certified EHR technology. Two, that it provides payment for covered professional services based on quality measures comparable to those used in the MIPS quality performance category. And number three, that it's either a medical home model expanded under CMS Innovation Center Authority, or that it requires to bear a more than nominal amount of financial risk. So either or. Next slide, please. So the previous slide that spoke about all of the things required actually are for the Innovation Center and anyone looking to develop or design an alternative payment model. You don't have to get caught up into the legalese there because we will not be able to put out a model that is not an advanced APM if it does not meet those criteria. So those are just for your background knowledge. Here's what's important for you to think about. Why am I doing this? You want to receive greater rewards for taking on some financial risk or some risk related to patient outcomes. So the risk would be, am I doing the work necessary according to the advanced APM criterion? And if you are, then you're eligible for the advanced APM specific rewards and the 5% lump sum incentive. And that incentive, again, is an incentive based on your participation in the advanced APM, not overall all the work you may do in Medicare. It has to be under that advanced APM. Next slide. All right, sorry for the delay, folks, but here we go. This is the slide that talks about financial rewards, again, more relevant to you. And this is where you will be talking to your organization executives or the leadership there. Hey, we're not going to be in the merit-based incentive program. So, hey, I'm not in MIPS. So the first column there talks about the MIPS adjustments. If you were in MIPS, you would be specifically included in the up and down adjustment there. If you're in an APM, then you could be generalized into a category that you receive some additional points. So you would still be eligible for the MIPS adjustments and some APM-specific rewards. If you're in the MIPS APM category, then you're going to get additional scoring points towards your MIPS adjustments, which gives you a lot more opportunity to do a little better there for the work that you do. But you also receive the APM-specific rewards. For purposes of the advanced APM, then MIPS is not going to be a category that you have to worry about because one of the exclusion criterion is if you make the qualifying APM participant, as you'll see at that column all the way to the right, the bottom piece, you'll be eligible for a 5% lump sum bonus, and then you also receive the APM-specific rewards. Next slide, please. So let's talk about the QP that I was just talking about, the qualifying APM participant. Under the QP, so some of the benefits are that you're excluded from MIPS, and that would be MIPS reporting, that you receive a 5% lump sum bonus, and that you also receive a higher physician fee schedule update starting in 2026. Next slide. And this is what we're looking at to determine whether or not you're considered a qualifying APM participant or QP. For 2019, we're saying that a percentage of your payments must be through an advanced APM. So for all of the work that you do, 50% of your payments have to come through the advanced APM. For the patient portion, and that would be 35% of your patients would have to be patients that you do work with through the advanced APM. And why do I say that? Is because we're going to do a calculation, and we are going to look at one or the other, and whatever one meets, then you would be qualified as a QP, meeting what we call the qualifying APM or QP threshold. And this table helps you see why it's important that you do a certain amount of work under advanced APM to get that 5% bonus and to be eligible to receive that. Next slide. All right, so what are the QP performance periods and what are the dates for that? One of the kind of important things here is to note that there's a performance period which is a specific year. And we're going to be looking at January 1st through August 31st to really measure how much work you did in that 9-month period with a 30-day run out. We're actually going to be moving to a place now where we're going to be looking at 90+% where we have reliability in the data and trying to get the data quicker than 90 days so that we can then measure, okay, if you did the work and you met those QP thresholds, then we can give you QP status. If we give you QP status, it will be based on the work you do January 1 through August 31st of that performance year. And that performance period then rolls into your incentive base period year. So that incentive base period year are going to be where we add up all the payments for Part B professional services furnished by the QP, so that qualifying participant. And then once that qualifying participant organization or entity, we then base the 5% bonus off of that year. So 2 years after you do the work, so you do the work in 2019, then 2020, we look at the incentive base payment period or the incentive payment base period. And then we actually issue the 5% bonus during the year of the payment year. So it'll be 2 years later because we want to give you the status, do the work, get the billing numbers, and then we base the 5% off of that 2 years later, and that's when the payment year is. Next slide. This is what I was talking about when I said January 1st through August 31st. So what we're going to do is take January 1st through March 31st, and then we would give you a snapshot of time just to say, in this period, we have calculated that you did enough work to make QP. If you did not, then we will then go January 1st through June 30th, giving you additional time. And we've given you these snapshots so that you have an opportunity to see how much work you're currently doing and whether or not you're in the proper realm of being able to get QP status. So we want to give you some snapshots throughout time. And then we go January 1st through August 31st, and that will be the end date for us to look at how much work you did to make QP status during that period. Next slide, please. So where can I check my QP status? One of the important things is that when you go to qpp.cms.gov, and I hope many of you have been there, you'll see that there's a QPP participation status. And if you have the 10-digit NPI number, you can enter that information, and it will let you know where you fall on a list of not only participants, but also on a list of how much participation you've done. Next slide, please. Here's a list of advanced APMs for 2019. We talked a little bit about this. You can find that on the comprehensive list of APMs fact sheet. It gives you a list of them and also their status and the specifics about the model. Next slide, please. And you can keep going. As I promised, I would give enough time for question and answer. So these next two sections, the all-payer and the MIPS APM section, we're going to go for about another 10 minutes or so to give enough time so that way we can allow for question and answer. So this will not be rushed, but here we go with the all-payer combination option. The beautiful thing here is we just talked about the Medicare option, and the all-payer combination option is very similar. So all we're going to do is we're going to look for any payer outside of Medicare, and when we include the work that you do there, if you're below the 50% or the 35% threshold that we spoke of, we will then take the full payments that you receive from all payers, and we will try to help you get to, based on calculations, the work that you did, we will try to help you get to those numbers to meet your QP status. So it's more inclusive, and that's where we get the all payer when you start adding other payers outside of Medicare option. Next slide, please. So this is just a lot of verbiage that kind of says exactly what I just said, but a little more specific. QP determinations under the all-payer combination option will be based on an eligible clinician's participation in a combination of both advanced Medicare APMs and other payer advanced APMs, in which we do determinations throughout the year during the open periods for you to send in, or your payers to send in that data. We're also looking at QP determinations that are conducted, and they will be conducted sequentially after the Medicare option, so that if you are already meeting QP status under the Medicare option, then you don't have to add in the all-payer combination option because you already met that number. And then any clinicians who do not meet the minimum patient count or payment amount threshold to become QPs, we want to use the all-payer combination option after to still try to help you meet. And this is beginning in 2019 during this performance period. Next slide, please. So these are the type of payers that we're looking at. We have the Medicaid. We also have Medicare Advantage, which is included under the heading of the Medicare health plans, CMS multi-payer models, and then also we've included this year the other commercial and private payers going forward. Next slide, please. So how does this work? We're going to look at the minimum that you have to do in Medicare of 25% for payment amount threshold and 20% for patient count threshold. And when you're talking to your clinician or your executive, they're going to say, well, we're already doing that amount of work. Yeah, but we must meet the overall 50 and 35%. So what we're going to do is we're going to take all of our payers, and I believe that we've done enough work with those payers that have been determined to be advanced APMs, that we're going to send that data in, and CMS will do a calculation. And as long as we're doing 50% of that, either payments or patients of 35% through all the payers, that's how you're going to meet the minimum to be a QP. Next slide. So this just reiterates what we just spoke about. If it's less than 25% of your Medicare work that's being done, then we will not be able to add in or add you up to get to QP with the all-payer. You have to be between the 25 and 50% for us to qualify you to add in the all-payer combination option. And then greater than 50%, as I previously stated, you don't need the all-payer combination option. It's not necessary because you've already reached QP status. Next slide, please. And this is just another reiteration, different presentation. Everybody learns differently. So the last three slides will put you in a position where you'll be able to see the information differently, but the same thing. Next slide, please. And we'll move on from here. Next slide, please. All right, so we talked a little bit about this, and you saw this earlier, this graphic on the right-hand side where APMs is a larger bubble, and under that bubble you have the MIPS APMs and the advanced APMs and how they touch one another, and they're a subset of APMs. The MIPS APM streamlines the work that you do, so you don't have to do duplicative work, And we're going to aggregate all of your eligible clinicians' MIPS scores to the APM entity level so that the group in the billing entity doesn't have to do repetitive work individually, but at a group level. All eligible clinicians in the APM entity receive the same MIPS final score, and this has to do with more of the MIPS payment adjustments. As you see here, there's also an APM-related performance that we're going to try to make sure that we capture all of the work that you do to help you, one, reduce burden, and two, maintain focus on the APM goals and objectives you're working on under the APM work. Next slide. So the difference between an advanced APM and a MIPS APM specifically, under the MIPS APM requirements, one, the APM entity must participate under the APM at the APM level under an agreement with CMS, meaning that we must be in agreement with you that you're in a MIPS APM. Two, APM entities must include one or more MIPS eligible clinician on a participation list. So if you're not eligible for MIPS, then you would not be eligible to be a participant under a MIPS APM. And three, that the APM bases payment incentives on performance, on cost utilization, and quality. Because it is MIPS eligible, then we need to make sure that we're aligned with MIPS side of that. And then the beautiful thing is that you don't have all of the risk that may be required under the advanced APM. So you're still doing the work, and you're still showing that there's quality of value, but without all of the risk. Next slide. So again, we still have those 3 snapshot dates that we're looking at, but the reason why we're doing this is because we're going to be looking at the list. That list is going to help us see whether or not you're participating in the advanced APM or the MIPS APM. The reason why we're doing this again is because those who are on the list, they will receive the APM scoring standard. You'll note that there's a 4th date here, and that is December 31st, because we are capturing the participants who may have joined after August 31st, but are still showing on the list, and those are going to be those that joined the Medicare Shared Savings Program, or the Shared Savings Program as it's called, and that is a full 10 model. So only that full 10 model will we be adding that 4th date and appending to that list, so you get the APM scoring standard. That is not relevant to the QP participation. That is only after August 31st through December 31st for those who join the Shared Savings Program to be eligible for the APM scoring standard. And I just wanted to make sure I reiterated that. Next slide, please. And then this is a list of your MIPS APMs. Like I said before, you'll find the same list in our resource library, and the resource library can be found under qpp.cms.gov. Go to the About tab, and then you can drop down from there. Next slide, please. And as promised, I will pass this over to Adam Richards. Thank you all for calling in and listening. And we still have time to meet the deadline for question and answer.
Yeah, so thank you, Corey, so much for kind of walking us through the basics of alternative payment models and the advanced alternative payment side of the quality payment program. Again, I think there's a lot to digest there, so we're going to give everyone just a moment to kind of let everything kind of sink in, get your questions together. Also give Corey a few minutes just as a breather here. Just talk a little bit about some of our resources that are available to kind of supplement your learning today. I believe Corey mentioned this earlier, navigating over to the Quality Payment Program website at qpp.cms.gov and navigating to the APMs tab. There's a lot of really fantastic information that is available in that APMs tab. We've created additional pages to really get into the nitty-gritty of some of the aspects of the alternative payment model and advanced alternative payment model tracks. We do have the overview, more information on MIPS APMs, the all-payer combination option, as well as just advanced APMs in general. I saw a lot of really good questions coming in specific to kind of each one of those different pieces of advanced APMs, so highly recommend checking out those pages as your time allows. I will also say, if we move on to the next slide, just another form of support that is available is our Quality Payment Program Technical Assistance. If you're not familiar with technical assistance, this is no-cost support that is available to those who are participating in the Quality Payment Program. A lot of this support does work specifically with MIPS-eligible clinicians, but I will say that both our Small Underserved and Rural Support Initiative, our QUIN QIOs, our Quality Innovation Networks, and Quality Improvement Organizations are also very capable of talking through advanced APMs and APM participation, and they're there to also help you prepare to move into an APM if that's really the ultimate result that you're seeking for 2019 and in future program years. Also highly recommend reaching out to our Transforming Clinical Practice initiative. This is a model test that does come out of the Innovation Center, but it is a model test that allows or that helps clinicians and practices truly begin to prepare for participation in APMs and advanced APMs. So another great initiative to really help you get started with the process if this is what you're interested in doing in the immediate future. So take advantage of all of those free support options that are available. Of course, we've mentioned the Quality Payment Program website, qpp.cms.gov. Highly encourage you all to sign up for the listserv at the very bottom of the screen on the main page. But also, if there are questions that we can't get to today, please feel free to send those questions to our service center. As you can see in the bottom right-hand corner, we do have the number for the service center as well as the email address, qpp@cms.hhs.gov. They are also able to help answer some of your questions around APMs and advanced APMs. So with that, we're going to charge forward to the next slide. I'm going to turn it back over to our operator to just go through how folks can get in the phone key, and then we'll get started in just a minute.
We are now going to start the Q&A portion of the webinar. You can ask questions via chat or via phone. To ask a question via phone, please dial 1-866-452-7887. The number again, 1-866-452-7887. If prompted, please enter ID number 447-8537. ID number again, 447-8537. Once you've entered the conference, please press star 1 to ask your question. We'll pause for just a moment.
Okay, and as we're waiting for folks to dial in, again, great questions kind of coming into the chat. We're trying to answer those as well. I will say, just as we take questions, we're going to do our best to answer programmatic specific questions around the quality payment program. As we went through the slides today, you saw we do have a number of advanced alternative payment models and just models in general. So we don't have everyone from our model team here and available to talk through some of the nuance of those models. So we may have to take some of those questions back and try to answer those offline. But we will do our best. So at this point, I think we'll take our first caller.
Our first question is from Candy Hansen.
Hi, everyone. Thanks for the presentation today. My question is about an advanced APM. How does an advanced APM show or demonstrate to CMS that 75% of their clinicians are using CERT?
That's a great question. So the CERT use is actually something that you would attest to, one, but also you would have to make sure that those participants in your organization on your participant list are actually using the certified EHR technology and attest to that measure or that amount of work. So what we do is we actually are, unless there's an audit, trusting that you have the documentation that you have been doing the work under a certified EHR technology.
Thank you.
Thank you.
So let me just, before we take another question, I think a few of these questions we can answer. There's a question about a 5% incentive payment. If you do the work in 2017, then the 5% bonus will be coming in 2019 based on the work or the payments under Part B professional services that was actually done in 2018. To that point, we're actually working on now a way to develop a fact sheet to help explain how the APM payments and incentives are applied and actually how they're paid out. So that will be coming shortly, not stating a date, but just making sure we get all the facts right and are able to articulate that in a way that it's easy to understand. I just looked at the document. It's not long at all, but straight to the point and helping to understand. The other thing that's mentioned here is there's other questions around, and a few of them around, what does it mean to participate in advanced APM versus receive QP status? So you could be participating in an advanced APM but not do a specific amount of work. And that work is, if you look at your whole amount of work that you've done as a clinician for the year, did 50% of the payments that you receive come through that advanced APM? So if you work in 2 different organizations or assign your billing rights and you look at the total amount that you billed Part B professional services for $100,000 and $50,000 or more came through that advanced APM, then that's 50%. Then you have what we call done enough or significant or sufficient amount of work in that APM. If you have 100 patients or more, let's just stick with 100 so the math is easy, then 35% of those patients must be through that advanced APM. So 35 out of that 100, for every 100 patients, you should be seeing 35 or more patients through that advanced APM. So if you have an organization that has 300 or your organization is seeing 300 patients, then 105 of those patients should be work done and attributed to that advanced APM work. If you're less than that, what we're saying is you're doing the work and you get the APM incentives, which is the next question that was posed. What do you mean by APM incentives? Sometimes the incentives are they may give you dollars in addition to what you bill for having a population that has more risk or a heavier population in one area or another. You may have patients that have more comorbidities based on the work that you're doing in the advanced APM, so you receive additional payments outside of the normal fee-for-service. You may receive additional benefits to help with the system or to pay for additional work outside of the clinician work. So something like that might look like having social workers or community workers that go out and support the work at a social determinants of health level. So there are additional incentives that the clinician and the practice don't always have to pay for. That we call those incentives because it doesn't come out of the organization's pocket, and sometimes it's additional dollars and sometimes it's additional support.
Thank you, Corey. We'll take our next caller.
Our next question is from David Lauder.
Hello, thank you for taking the call. How can I'm representing a Track 3 ACO that's qualified with 35% patient participation in 2017 or 2018. I'm trying to figure out how I can estimate our level of participation in 2019. Do CMS reports give us any clues to the volume of attribution eligible patients that would be expected to be in our denominator?
So the good thing that you're speaking of is that we were just kind of thinking about, did we talk a little bit about the lookup tool? So when you go to what we require is a login, if you have anyone who is able to create an account or someone as a security official or someone who is assigned the rights to actually go in and look up the specifics, we are giving percentages so that you understand how we based QP. And we're also looking at patient and payment amount percentages under the QP and under your APM participation. So a lot of the details are right there under the lookup tool, and that lookup tool will tell you about the work that you're doing under MIPS, and if you're doing work under an APM, we'll talk about that too. And then we're also talking about what understanding we have based on the participation list and also your assignments to what we know about you. So that way we begin to get to a place that we're communicating and telling you what we know, and then you can cross-reference that with what you know. And if there are other things that you find helpful, please look at the website and you'll find there are places where we have opportunities for additional research, and that's for anyone on the call. If you want to become a participant in any of the research that we're doing, we're focused on human-centered design and design thinking. How do we incorporate and include the user in the work that we're doing? So if you find that there's value there to test some of the things that we are designing or looking at doing, you'll notice that QPP.cms.gov has a different look and feel than just the CMS.gov. Please proactively email, look out, and let us know how you want to participate.
So those numbers in the QPP, because I went there for the practices, so those numbers represent the attribution eligible number of beneficiaries and the overall billing under the physician fee schedule in Part B?
So part of it is what you're looking at is a percentage of clinicians' work based on payments and patients. What you're speaking about when you talk about attribution eligibility, you're speaking about the specific calculation numbers. We do have a QP methodology paper, but attribution eligible has to do with the type of G codes, what model you're in. It gets very detailed so that, and what the gentleman's speaking of for those on the call so we don't lose people, is that two clinicians in the same organization could be seeing the same patient, but only one of them will actually get attribution or be assigned as that clinician. So that way you don't have one patient seen by 10 physicians, and then all of those physicians get assignment for that patient or beneficiary. So attribution eligibility is important because you may be seeing 105 patients, but they should all be 105 different patients. So if you look at the QP methodology paper, that should help you figure out and see how we use that number for the calculation that you see on the lookup tool.
Thank you.
You're welcome.
Your next question comes from Susie Burr.
Hello. This is Susie. I had a question, and we came across, I work with the QIO in Texas. We came across a large group this week that has been preparing to report at the group level, and they're getting ready to report. They're going into the QPP portal to find that 12 of their high-performing doctors that do most of their volume, actually they thought all of their volume at their location, are actually allotted to an ACO, which was a real surprise to them. They have reached out to the ACO to see if they can get a participant file list from them to confirm the status. Is there a CMS contact they could also reach out to for this? They feel confident that many of these physicians do they thought all of their services at their locations. That really kind of caught them off guard. Just wondering what next steps should look like.
Yeah, Susie, I would highly recommend having them reach out to the service center so that we can create a ticket and track this, and then it will get to the right folks so that we can take a look at the specific situation.
Okay, great. Thank you very much.
Again, to ask a question, star then the number 1. There are no additional audio. I'm sorry, we do have an audio question that just came in. One moment.
Sounds good.
Our next question is from Kathleen Randolph.
Thank you for taking my call. These sessions are always very informative. In regards to the 2019 MIPS reporting performance measures, we're a part of an ACO, and one of the questions that I have that I cannot seem to get clarification on deals with the Public Health and Clinical Data Exchange. Because we are a part of an ACO and we are a specialty office and not a PCP office, are we required to participate in a clinical data registry for 2019, or is it still considered a bonus? I know we would be exempt for the immunization reporting, and we do not have syndromic surveillance in Florida.
So this probably come from the shared savings program. So please help clarify if I'm not answering your question. But if this is a group that's participating in a shared savings program ACO, is that correct? Or no? Okay, well, if it is a participant in a shared savings program ACO, then the ACO would be reporting on behalf of the participants in terms of for the quality performance category. So they would be reporting the CMS web interface and CAHPS for ACO quality data that would be used to calculate the quality category under the APM scoring standard.
Correct, but as far as what we're responsible for, we are responsible for the PI portion. And it was my understanding that one of those measures actually had to do with the public health and clinical data exchange. I don't know what the measure number on that is, to be honest with you, but I'm trying to determine whether, again, if what you're saying is true, that the ACO would pull that data from all participants and meet the measure that way, or whether we're supposed to do it individually as a practice.
Right. So I can't speak for specifically about how PI is reported and which measures must be reported, but the ACO would not be reporting PI on behalf of your group. So you would still need to report. I would suggest emailing the Quality Payment Program Service Center so we could help.
Yeah, I think one of the difficulties we often run into is there's overlap, certainly between MIPS and advanced APMs. So this is one that I think we have to have answers from a couple different folks on just to make sure we're giving you the best guidance. So
Can you give me the email address?
Yeah, I would say if you send us a note to the Service Center and let us know that you flagged this for us on the webinar, we can certainly get you the information, and that's qpp@cms.hhs.gov.
Okay, got it. Thank you so much.
Thank you. Okay, folks, we are at the top of the hour. Just to be respectful of everyone's time, we are going to wrap up our discussion today. A couple of takeaways, a couple of big pieces. Please visit qpp.cms.gov for more information, particularly around APMs and advanced APMs. Again, highly encourage you to sign up for the listserv. We will be doing more deep dive webinar sessions on many of the topics that we focused on today, and we took a lot of notes just from our conversation here during the Q&A. We know where there are areas that we should be focusing on as we move forward in 2019, so we'll make sure that we are tailoring resources around those areas. Also, as Corey mentioned, there is the opportunity to participate with us in user research. If you are interested in participating, feel free to send us an email with your interest at qppuserresearch@cms.hhs.gov. For now, we are going to leave you with that. I thank you all for joining us today, and we'll talk to you again soon.
Thank you. This concludes the Q&A portion of the webinar. You may now disconnect.